Yeah, go ahead, Vikram.
Yeah, good morning, everyone. Today we have Dr. Amir Hassan. He's heading the neuroscience department in University of Texas. He's also director of endovascular surgical neuroradiology in Valley Baptist Neuroscience Institute. He's well recognized for research in stroke, artificial intelligence, advanced imaging, aneurysms, and AVM treatment. He has more than 250 publications. Today, he has accepted to talk about mechanical thrombectomy in low aspect patients. Welcome, Dr. Amir Hassan. You can please start the session.
Thank you very much, Vikram. Thank you for the invitation, and honored to be presenting to you all. So I decided basically to spice up the talk a little bit and give you guys a little bit of a presentation on the SELECT-2 trial. I'm the endovascular chair for the trial. Dr. Amru Siraj is the PI. And it's basically a randomized trial in Europe and the United States, looking at optimizing patient selection for endovascular treatment of acute ischemic stroke. And the focus is on low aspect patients. So here are my disclosures. So overall, global PI is Dr. Amru Siraj, and I am the endovascular committee chair. Here are the steering committee chair members. You might recognize several of them from across the world. And overall, we have a lot of information and a lot of positive studies on endovascular therapy. Its efficacy, its safety, and we all know that it works, but all of those studies, all 7 randomized trials, looked at patients with minimal ischemic changes, small cores. Aspects were typically greater than or equal to 6. The cerebral blood flow, which in our studies was calculated to be less than 30% on CT perfusion, the CBF volume, had to be less than 50 to 70 cc's. So based on the rapid definition, IschemiView's rapid software, for us, that was the definition of core if you used CT perfusion. So these are just some examples of patients enrolled in SWIFT Prime and other studies. This patient, for example, had a very good aspects score and had no CBF, less than 30% volume on CT perfusion with a large penumbra. Patients with a large core were excluded from almost all of these trials. And even in the DAWN trial, we excluded the patients with greater than 51 cc's of infarct. So aspects less than 6 or CBF greater than 50 to 70 cc's volume typically were excluded from trials. For example, one of the CTs on the left, and an example of a CT perfusion in a patient that was excluded from the SWIFT Prime study. As you can see here, there's about 89.6 mLs of infarcted tissue based on a CBF volume rapid report, and then the penumbra was 226. The thing is, a lot of us, especially on this call, on this webinar, and you know, I'm sure you've all heard Tudor Joven speak and Vincent Costela. You know, these guys are the co-PIs for In Extremis. We do take these patients, right? We all do treat these patients that have 226 mLs of perfusion deficit with only 89 mLs of infarct. For us, that's still a lot of tissue to save, but there's no evidence today. So what is the large core definition? Well, it differs between CT and CT perfusion. So CT aspects detects hypodense tissue. Perfusion imaging really defines it based on very low blood flow or volume. So aspects of 4 in this patient comes out to a volume of about 92 mLs if you're using CT perfusion. These are the same patients. Now, looking at a different aspects of 4, and this is one of the reasons why we all, most of the SVIN members, agree that we should come up with a new type of aspect score, right? It should be based on eloquence. Eloquent area is not just a straightforward image because when you hit, you know, M1, 2, 3, M4, 5, 6, those areas don't have the same impact as hitting, for example, the internal capsule. So this patient has an aspect of 4 on the bottom left, and his CT perfusion CBF volume was about 174 mLs. So as you can see, 2 patients with the same aspect score, but almost 80 mL difference in CT perfusion. So we published this paper. It's not that long ago, and it was published in JAMA of Neurology using the SELECT studies data. What we did is we looked at the outcomes of endovascular thrombectomy versus medical management, but we looked only at the large ischemic core patients. Remember, this was a prospective study, and all patients that were enrolled had CT, CTA, CT perfusion performed. And then it was based on the decision of the operator whether or not the patient would be included based on whichever study he was comfortable with. So if Dr. Techley, my partner, and I enrolled a patient, we typically enrolled that patient based on CT. If we thought the CT looked good enough, we enrolled the patient. We didn't care what the CTP showed us. Other people chose the CT perfusion. So it was good to have a mix of sites. As you can see here, it was us, University of Texas, Houston, Stanford, several hospitals in Atlanta, high volume centers, Cleveland Clinic, and others. So what we found was the patients who received thrombectomy, as you can see here, 62 patients versus the medical management patients, about 43 patients, there's a significant difference in modified Rankin 0 to 2. So we said, okay, well, there's something important here. So good outcome was 31% in the treatment arm versus 14% in the medical management arm. Now, it's not as good as 60% good outcome in Swift Prime, but that doesn't matter, right? We can still help these patients. I'm sure you've heard either myself, Raul, Tudor, we all keep saying number needed to treat in the United States and in the world we think is way too low. We think we should be doing a lot more mechanical thrombectomy on patients. Look at STEMI treatment. The number needed to treat for acute MI is 17, right? Whereas in stroke, it's 4 if you use the Swift Prime data and 2.5 if you use the Dawn data. So we're being too selective. So if I can still double the amount of patients who have good outcome from 14% to 31% with an odds ratio of 3.27, p-value of 0.03, why not? So as you can see, significant results with good outcome and shift analysis, whereas the symptomatic ICH, there was no statistically significant difference, but as you can see, the thrombectomy patients had less hemorrhage. So symptomatic ICH in the treated patients was 7% versus 13% in the medical management arm. Mortality was 29% versus 42%. And fortunately did not reach statistical significance, but hey, if we have good outcome, that's what most of neurology cares about. Modified Rankin 0 to 2 at 90 days. So the objectives of the SELECT study was to evaluate the efficacy and safety of thrombectomy compared to medical management alone up to 24 hours. Since we do have the Dawn data, I understand that the American Heart Association guidelines only recommend up to 16 hours because according to them, 2 studies covered that window. We would need to do another randomized study. Nobody in their right mind is going to do another randomized study. So we're going to treat up to 24 hours. It really is tissue. It's not time. So up to 24 hours in large core patients. I know In Extremis and Tesla are 2 other studies going on currently in Europe and the United States. They have different definitions. I don't believe in those definitions. So I'm going to tell you based on what we see, we're using CT aspects 3 to 5. I really don't think you're going to get any benefit from treating an aspects of 1. So let's just say that. Now, for those patients who want to use CT perfusion or MR perfusion, if you have that luxury, we're looking for greater than 50 cc's to evaluate the heterogeneity of thrombectomy treatment effect on CT versus perfusion imaging. So first of all, we're looking at mechanical thrombectomy versus medical management. These are the first 2 big groups. Then the other thing behind the scenes, there is half the camp believes that CT is going to be enough. And I don't need all this fancy software. I'm not going to need, Viz, AI, or Rapid specifically for CT perfusion. Now, I still might need it for CT and its communication tool and for CT and angiogram. But do I really need to waste time doing a CT perfusion? And I think that is the second question we're going to try to answer. So it's designed as a prospective, randomized, multi-center, open-label phase 3 clinical trial, blinded outcome assessment. There are 30 sites across the US, Canada, Europe, and Australia. Inclusion ages between 18 and 85. Patient has to have an intracranial, carotid terminus occlusion, carotid lesion, M1 occlusion. NIH stroke scale has to be 6 or greater. Baseline modified Rankin of 0.1. Very similar to most of these 7 studies that were published back in 2015 that all had positive outcomes and showed us that we should be treating patients with mechanical thrombectomy. Now, it's an adaptive design, so it's adaptive to time and imaging. The last thing we want is to have a lot of patients in one time or the other, or a lot of patients to be chosen based on CT and not CT perfusion. There's covariate adaptive randomization for balanced baseline characteristics, because we also don't want to be treating a lot of young patients and not including the older ones, which I actually think that we're probably going to have the other problem. I don't know if the CHARM study is currently enrolling patients in India or not, but the CHARM study, for example, closed the enrollment to patients over 75, I think 70 to 85 window, who had mechanical thrombectomy. It's closed to those patients because they were enrolling so many patients in that arm and not enough in the other arms. So they basically don't allow us to enroll any more patients in that arm. CHARM is a neuroprotective study using glyburide. So the enrollment target for the study is 560 patients, and 2 interim analyses will be performed at 200 and at 380 enrollments. So the thrombectomy efficacy and safety in patients with large core. Large vessel occlusion, like we said, carotid or M1 occlusion, we're trying not to include M2s, has to be within 24 hours. And like we said, baseline modified ranking 0 to 1, NI stroke scale greater than or equal to 6 at presentation. So the patient's going to get all the studies, CT, CT angiogram, CT perfusion. Now, patients who have an aspects greater than 6, greater than or equal to 6, or if their core volume is less than 50 cc's, those patients obviously are excluded, right? Those are patients that you should be treating anyways. So there should be no randomization going on. Now, if your stroke patient has an aspects of 1 or 2, guess what? We're not going to be treating that patient either. Now, unfavorable profile is what we're looking for. CT aspects 3 to 5 or CTP showing greater than 50 cc's infarcted tissue. And then the patients will be randomized, like we said, covariate adaptive randomization, mechanical thrombectomy plus medical management, or medical management alone. It's an adaptive design, adaptive to time and imaging. So we don't want to have too many patients in the late window, or we don't want to have too many patients, treated right after thrombolytics, for example. And we don't want too many in one arm from CT or CTP. Now, after we've excluded those patients, and now we're looking at specifically the select 2 patients, both thrombectomy and medical management arms. We're going to be breaking them up into 3 groups. Because why? We really want to know the imaging selection analysis. What's going on here? If a patient has an ischemic core greater than or equal to 50 cc's on CT perfusion or MR perfusion, but their aspect score is 6 to 10. So that's by definition favorable CT, unfavorable CTP. That's one group. The group 2 would be, of course, the patient who has unfavorable CT, so aspects 3 to 5, and then a favorable CT perfusion. So the ischemic core was less than 50 cc's on CTP. And then finally, group 3 are the patients who both of those would meet technical criteria for enrollment in Select 2. Aspects 3 to 5, as well as ischemic core greater than 50 cc. So unfavorable CT, unfavorable CTP. Now, analysis 1 would be good outcome rates in thrombectomy patients. Non-inferiority margin 15%. Analysis 2 will be heterogeneity of thrombectomy treatment effect. And then, of course, analysis 3 is EVT superior to mechanical thrombectomy in patients, specifically with a favorable CT and unfavorable CTP. So like we showed earlier, your patient who potentially had that aspect of 9 or 10, and it looks great on CT, but the CT perfusion did show core greater than 50 cc's. If those patients, if endovascular is superior in those patients, that really means CTP is excluding patients from mechanical thrombectomy. So overall, and here's some context. Dr. Amr Siraj is the study PI. Here, the 24-hour select hotline, and here are the coordinators. And to be honest, the rest of the time, I want to kind of field questions from you and discuss what you think about the design of the trial. Anybody want to talk specifically about the data that we had that was published from the Select 1 study?
Yeah, Amir, nice talk. Actually, why you have taken 50 cc as the perfusion cutoff in Select 2?
Instead of what?
70 cc, up to 70 cc, whether it is equal to aspect 6?
No, so it's one or the other. So the patient could have ischemic core volume greater than 50 cc's or aspects 3 to 5. You don't have to have both criteria. But I agree with you, actually. So this obviously was, went through several revisions before we finalized the study. And you have someone like Greg Albers, world-renowned CTP guy, and really pushing for the definition to kind of stay lower. He was afraid if we pushed it to 70, we might not get the results that everybody thinks we're going to get. So to be honest, if you look at the Dawn criteria, the cutoff was 50 cc's, right? So if you had 51 cc's, you were not enrolled in the study for the younger patient group. So that's why we chose 50, because there is no evidence to prove you should be treating patients with an ischemic core greater than 50 cc's based on the 7 randomized trials and Dawn and Diffuse 3.
Okay, but in India also we are doing few borderline aspect patients. If they are young, right hemisphere, and I think if they come early. But I think few of them they have reperfusion, edema, and we have to do early decompression. Whether early decompression is a criteria in your trial?
Early decompression, no, but that's a very interesting fact that you picked up, Vikram, because in one of the things that Qureshi and I were looking at, I think we presented it maybe 2 years ago at ISC, after the positive trials, besides the shift in good outcomes, if you just look at the patients who had poor outcomes, like remove all the good patients on the pre and post mechanical thrombectomy stent retriever error. One thing you notice is a significant decrease amount of craniotomies, right? You have less patients dying and less craniotomies. So overall, patients who were classically treated with mechanical thrombectomy were these really good patients. And that's what we concluded. We concluded that we're screening too well, because that means we should be giving everybody a chance. So I agree with you. I think if we're treating these borderline patients, aspect 4 or 5, you do get cerebral edema. You do craniotomy. The question now really is, how would they have done if you didn't do mechanical thrombectomy and they had 250 cc's infarct instead of only 80 cc's infarct? And what are you seeing in your practice?
Yeah, a few of them they do very well, actually, and
yes,
yeah.
And that's what we're
MRS,
seeing.
and whether saving eloquent area, so all those things, and I think saving some neurons will help in neuronal plasticity and recovery.
So this is a good question. So how many, Deepak was text everybody, question everybody, how many hospitals give aspect score in India? So what do you guys usually use in India? Are you using more CT perfusion or just selection based on CT?
So majority of, I think, hospitals, they use CT, and few of them, they use MR. But in the reports, I don't think anyone gives aspect score. I think as a neurologist, we need to calculate it and decide.
Okay.
Yeah, I mean, it's not officially given by the radiologist. Not as far as I know.
Okay, so here's a better question for those of you who are on, since we have a good audience. How many, is there a way, I think we can answer live. It says, let's try this.
We can take we can do an opinion poll. Only problem is the polling works only when people are on the phone. It doesn't work when they are on their laptop. So many people are on laptop.
Oh, okay, okay.
We can ask people to maybe just write in the question answer. They can write.
Yeah, just right. Ask using
I'll
aspect
make
or
a poll.
CT.
I'll make a poll. What is the question you want to ask?
Basically, I want to know if who's using aspects for selection, and then who's using CT perfusion.
Okay. Okay. Let's. I think you can ask just now, and the next question maybe I'll prepare it next time very fast online.
So someone was asking, is there subgroup analysis depending on the time to endovascular? Yes. So we do plan, and that's one of the reasons why it's an adaptive design to time and imaging. So we will look at the benefit of treating, for example, patients within, for example, 6 hours, the original SWIFT prime criteria. If these patients who come in with large core, but by our definition, unfavorable profile, if they do better with mechanical thrombectomy versus medical, or if it's only we see it in the late window patients, which would, to be honest, make more sense since those patients typically have better collaterals. Okay. Why posterior circulations are not included in any of the trials? So that is a very good question. There was a posterior circulation trial done in China. Unfortunately, there's too much crossover. You know, when you do research, you have to stick to the rules. And when you convert patients from the medical arm to endovascular arm, then you muddy the waters. So that trial, I think it was a couple of trials done, but unfortunately, none of them answered the primary question. So they are designing some stuff now, and that should be coming out soon. But unfortunately, it's a different animal. I'm sure you know the NI stroke scale is very heavy on the anterior circulation. And it really gives only a few points for posterior circulation. So we would have to enroll patients, and even their follow-up and everything, we need something else besides NI stroke scale. We need better scales for enrollment and for follow-up.
Many of the posterior circulation strokes look like chameleons. They don't present as strokes. So it may look like
Yes.
attack of vestibular neuritis. It may look like diplopia.
Yes.
He may go with vision symptoms to an ophthalmologist. So they are likely to come late to the neurologist, unlike the anterior circulation.
Yeah, Amir, same thing. So here we are going down on aspect. So should we also increase the MRS score in these patients? Like whether MRS 3 is okay? If he is able.
Excellent question. So this is how I present it to my patients, because I have been treating these patients for years, right? We were doing Dawn criteria before Dawn study. And then even after Dawn, we were treating large cores, and now we have a trial to treat them. So we've always been doing that, and that's the way we explain it when we get consent. We always explain to the patient, okay, the studies looked at this specific patient, right? You know, 18 to 85 and good baseline and XYZ. This patient who comes in might already be a modified Rankin of 2. This patient might have, you know, a very high NIH. Those are two issues what we always bring up. Excuse me. And then the baseline CT that is done, or CTP. And we tell them, there's no evidence to prove that will significantly improve. But right now we are seeing there's a shift. We're shifting patients from dead and disabled to, for example, modified Rankin 3-4, where he's using a cane, right? He's using an assisting device. Yeah. So would you want to be aphasic and plegic, or do you mind walking with a walker? And most patients actually, you know, it's very rare if a family has ever told me, no, I'd rather be dead than be treated. Most patients say, no, treat me, please. So I agree. I think we should have more tolerance in this group because they have nothing to offer, right? And in MI, the outcome is mortality, right? The final outcome is whether the patient died or not. But if the patient, you know, needed a balloon pump for God knows how long, that's not considered for them. You know, as a neurology, I think we made the criteria very strict on ourselves back in the IVTPA days, and we kept that criteria into the mechanical thrombectomy days. But just seeing a shift in mortality, seeing a shift in craniotomies and mortality in craniotomies going down, that's fine. What's wrong with modified Rankins 3s and 4s if they were going to be 5s and 6s? But in the end of the day, you know, to get level 1A evidence, we're going to have to also show that there is a shift in modified Rankin 0 to 1, which I'm very comfortable, you know, saying that we will find it. You know, we need to do the study, but I know we're going to do the study and we're going to find that answer. So we have a couple of good comments here. So it is very important to give maximal neuro ICU care post-thrombectomy. Otherwise, you lose a lot of cases. Definitely. That's one of the reasons why Qureshi actually used to recommend all of his fellows had to be neuro ICU trained. So I trained with him, obviously, in Minnesota, and we all had to do neuro ICU full training and endovascular. And we all started neuro ICU services in most of our hospitals. And then as the service grows, you hire neurointensivists because you can't be running around doing cases and rounding neuro ICU all the time. So I do very minimal these days. I do maybe, you know, 4 or 5 days a month of neuro ICU service. Whereas when Tekli and I built the practice, it was basically you were 1 week neurocrit, 1 week endovascular. And we just flip-flop that way for almost 3 years. It is very important to control blood pressure parameters. I think if you get recanalization in these patients, we always drop their blood pressure below 160. We actually, Tekli likes to do 110 to 150. I do 110 to 140. If I don't see high-grade stenosis, there's no ICAD, no severe ICAD or carotid stenosis, I will, after mechanical thrombectomy in a large core patient, I always drop their blood pressure below 140. And unfortunately, yes, what you're saying is right. Neuro ICUs are a rarity in India, but remember, when I started and when other people started, we didn't have a traditional neuro ICU. We had our patients admitted to CCU, medical ICU, whatever ICU it could get a bed, and we would just follow these patients and give the nursing orders. Next question. So if the patient has good aspects, but with complete ICA occlusion and M1 occlusion, what do you suggest? So yeah, we treat this patient. If he has a good aspects, we would treat a patient with a complete carotid and M1 occlusion because that patient won't do well otherwise. Do you use anticonvulsants routinely? Not for post-mechanical thrombectomy. Anti-edema measures post-procedure, it's not standard of care unless we see, obviously, you know, typically we'll do imaging 24 hours later, unless there's a change, significant change in neuro. We will keep a very close eye on these patients. They're always admitted to a neuro ICU, Q1 hour neuro checks. And what you see is any hint of edema, Dr. Tekli and I immediately start hypertonic saline. So we use 3% as our primary. And it's funny because I'm sure most of you have read this week that the Neurocritical Care Society updated their guidelines for cerebral edema. And most of it was unfortunately a lot of low evidence recommendations. But for cerebral edema post acute ischemic stroke, the primary recommendation was hypertonic saline drip. And they actually prefer boluses. So we have a protocol. We do 3% saline, goal sodium between, it depends what type of patient. So for acute ischemic strokes, we try not to do high protocols unless we see the tissues completely infarcted, right? If a patient has large territory infarction, we know they're gonna have a large stroke. We do the high sodium protocol. So the goal sodium is between 150 and 155. So they titrate the 3% based on that. So we titrate 3% based on Q6 hour sodiums, and the goal sodium is 150 to 155. And we'll add mannitol as well. If hypertonic is not enough, we'll also add mannitol. But most of these patients, especially if they are young, early craniotomy is the best way to keep them alive.
So how you decide on craniotomy? Because our surgeons, they want GCS to fall. It's few of them they do depending on the amount of damage. So how you decide?
So that's, for us, it's a combination of the two. So we will look at the follow-up imaging. So the patient always, say if the patient did not have a change in mental status, right? no decreased GCS. 24-hour MRI shows large stroke with surrounding, edema. We will typically start the drips, hypertonic and mannitol, and we watch these patients like a hawk. If it's a young patient, so in my mind, a patient under 55 years old, we would call neurosurgery and tell them, hey, this patient has a complete infarct. He's probably going to need a craniotomy. Look at the images because we don't want to call you in the middle of the night. And most of the time, when you discuss it with him like that, he'll do it, right? Because he doesn't want to be called in the middle of the night. But most of the time, to be honest, these patients, it's secondary to change in exam before we notice change in imaging. So these patients will become much more drowsy. Their GCS will start going down. We'll notice worsening neuro exam. And we're very good about minimum in the first 24 hours, you're getting Q1 hour neuro exams. Then it goes to Q2 hours. So you're still getting a good neuro exam every 2 hours on these patients in the neuro ICU.
What about the midline shift? Do you have any figure to it? 2 mm, 3 mm, 5 mm, or?
No, unfortunately, we tried to, one of the neurosurgeons we used to have here is an older gentleman, Dr. Six from Tanzania. Very funny guy. And he would be like, oh, there's only 4 millimeters midline shift, but the patient's comatose. I don't care what the midline shift is.
Right.
So for us, it's like I said, it's always the combination. So if the patient has a poor exam, or sudden change in exam, that patient will be getting craniotomy. If the patient has a good exam and it has 5 millimeter midline shift, it doesn't matter. We'd start hypertonic and mannitol. Now, if I see 10 to 12 millimeters of shift, yes, we're probably taking that patient immediately to the operator.
Even if he's not drowsy.
If the patient is not drowsy and he's got 10 to 12 millimeter shift, yeah, we're going to tell that family, listen, this patient is going to go south. Whether it's now or in a few hours or tonight, it's going to happen.
Why do you use mannitol or saline? Because that, once you, isn't that making the situation a little unstable? If you think he's got a large infarct, he's drowsy, then maybe till the neurosurgeon is dropping in, one could use, but otherwise, what is the rationale?
Because if you can prevent craniotomy.
It doesn't.
So a lot of our patients never go to craniotomy because you're controlling the cerebral edema and you're controlling the mass effect with hyperosmolar and hypertonic agents.
Okay, so this maybe you would try in the daytime, or if the person comes at night, you try.
No, I mean, overall, we're talking, remember, not every stroke is a complete hemispheric infarct. So we're talking 50 cc's, 80 cc's, 90 cc's, less than 100 ml infarct. Most of these patients, you can control the swelling with just hypertonic and mannitol.
Okay. What about?
I mean, at least this is what I've seen in our practice. Obviously, we have a lot of alcoholics here, so they have maybe a little bit more space. But younger patients, yes, I agree with you. When I had my 44-year-old stroke a few weeks ago, we didn't play any games. That patient, MRI 24 hours later, he wasn't looking too hot. His GCS went down, but not a lot. He was still, used to sternal rub. You wake him up, he follows commands, but he was getting drowsy. And then the MRI showed massive infarct. That patient, we don't waste time. You're going to take him to the operating room because he's drowsy, right? He's drowsy. He's not staying awake.
Yes. One more question was, sometimes we do have older people and yet their brain is very tight. There is no atrophy, though their brains behave like younger people sometimes. So
yes, of course. We have a lot of those as well. A lot of very, good, we call them the good 70-year-olds. And they have, very nice full skull, unfortunately. And then they do get some mass effect. So what we do, those are a harder decision because neurosurgeon will always fight back that there's no benefit in craniotomy in patients greater than 65. And that is published, right? We know that. That is, multiple studies have shown this. There's no benefit over 65. So it's always, you have to talk to the family, you talk to the surgeon, and you basically say, hey guys, this patient is not your typical 75-year-old. He's fully functional. He was playing golf yesterday or whatever he was doing, and he's not, your nursing home patient. That's typically the way we answer, those patients. Do better to consent for craniotomy when you go for thrombectomy? No, I mean, most of our patients, families are very, very accessible. So I would not say get a consent for craniotomy, because when do you know if you're going to open it up or not? Usually you're going to wait at least for the 24-hour imaging. Most patients don't develop significant cerebral edema until day 2. So I wouldn't say treat it early. CTA source image-based perfusion assessment, your comments. So I know my young Goya loves this stuff, using the CTAs and collateral scores and using perfusion based on CTA source. I don't like it. It's every system does it differently. So unfortunately, it's until it's more standardized, I don't agree with it, because there's just too much variability. Isn't it a rule of thumb that underhydrated patients should receive 3% and those with overhydration or cardiac should receive mannitol? Typically, I don't know, there was a couple of studies that came out in the US that most strokes come in dehydrated. It is very rare that a stroke patient will come in overhydrated. Now, yes, if it's a cardiac patient and we know that they have low ejection fraction and he's a known patient to the hospital, we will go with with mannitol first and not go with hypertonic saline first. So that's a very good point. When you want to start saline mannitol after thrombectomy, we typically will not start anything unless, again, so either the 24-hour imaging shows severe edema, or there's a change in mental status. And we will start hypertonic saline mannitol. And the idea is the smaller infarcts, I'm trying to prevent the patient going to craniotomy. And with the large infarcts, you're just buying them time until they go to the operating room. When do you start withdrawing anti-edema measures? So this is a very good question, because I had this debate a lot with one of my attendings at the University of Minnesota. You have to gradually wean the stuff. Qureshi also published a paper. Qureshi did a lot of the initial research on hypertonic saline with canine models when he was a fellow at Johns Hopkins. So a lot of the stuff is old literature. And what they found is you get rebound edema. If you drop the mannitol immediately, or just DC the stuff or wean it very quickly, you get rebound edema. So in our hospital, minimum is 24-hour wean for hypertonic saline. But typically, if it's massive edema and a patient was prevented from getting a craniotomy, we will do a 48-hour wean of 3% joint. And we still follow the sodiums closely for an additional 1 or 2 days to make sure it doesn't drop. So very good question. Experience and comments on PC aspects. It's an interesting point. 5 minutes. The complete study, we do use PC aspects for our complete study, and we were supposed to be presenting the data at ESOC, supposed to be presenting in Vienna in a couple of weeks, but it's obviously the meeting is postponed till November. So I do think it's good. I think it could be better. That's basically what I'll say about that. I think one of the big problems with it is there's still too much variability in outcomes. And I think the best thing is if these patients come in early, they do very well. It's very, very hard for me to continue to do Basler's really outside the window when I have already seen ischemic changes on the CAT scan. So if you see, already brainstem changes on CAT scan, and people say, well, you should treat these patients, they're gonna die anyways. I don't agree, because a lot of these patients will still die, and then you get a treatment for no reason. So if the patient has any ischemic changes in the brainstem, I do not treat posterior circulation. Some patients come late. There may be GCS 3 to 5 or decerebrating. When should you not go for craniectomy? Very good question. So again, it really is about how they came late, meaning that they came assuming within 24 hours, but maybe at 23 hours. They had met this criteria. We opened them up. Follow-up CT shows 100 ml infarct for example, and their GCS is down to 3 or 4 or 5, I will be having a conversation with the patient. Excuse me, ma'am, if this is the husband or the wife, the significant other, I truly don't think a craniotomy is going to get him better. It might prevent him from dying, but it will not make him better. And that's typically the way we go about that. Because to be honest, if he's an old patient, he was already disabled, or he has multiple medical comorbidities, yeah, what's the point? He's going to be sitting in your ICU for 3-4 weeks, and then in the end, he's PEG, trach, nursing home. So if the family wants that, sure, we'll do it. But most families don't. How do you decide posterior circulation strokes based on CT? Do you consider DUI in such patients? Again, I don't do MRI for these patients. I just look at the CT. If there is any changes in the CAT scan in the brainstem, significant change, of course, I do not treat the basilar. How common is delayed edema in your practice? Not related to rebound after mannitol withdrawal. So that's a good question as well. I typically have seen up to maybe day 5, day 7. I haven't seen it past that. So not any more delayed than that. Special population group like pregnant or age less than 18 years old. Your experience and comments. So in pregnant patients, they actually do very well. I think every pregnant patient we have treated has done phenomenally well, whether it's cerebral venous sinus thrombosis or classic stroke, M1 carotid. And less than 18, for us, they're mostly from secondary to trauma. Most of our kids are dissections, carotid dissections, vertebral dissections, then get a thrombus and come in. Those patients, again, they do very, very well. These patients bounce back like crazy. I actually highly recommend you to treat patients under 18 because it's very easy, and most of the time, like Alex Bernstein says, I only treat kiddos because kiddos bounce back. Even when he screws up, they bounce back. So I do recommend treating children. They do very well. And thank you for the great questions, everyone. Thank you for inviting me. And hopefully I'll see you guys at another meeting very soon.